This is a Healthcare Home sponsored webinar, and the title of this webinar is Understanding Billing for CHW Services in Minnesota, Medicare and Medicaid. We have a lot of people signed up for this webinar today, so you are all muted, and if you come off mute, we'll meet you again. Also suggest that since we have so many people on the call, that you diminish your cameras unless you're speaking. And also that you diminish any browsers that you might have open. That will make it a better quality webinar for everybody. So without further ado, I think I'm going to turn this webinar over to our lead presenter today, Kristen Godfrey Walters. Kristen, take it away.
All right, thank you, Carol, and thank you everyone for joining us today. My name is Kristen Godfrey Walters. I'm the Community Health Worker Training Program Director with the Minnesota Department of Health, Health Promotion and Chronic Disease Division, where I provide oversight and direction of state and federally funded community health worker initiatives in close partnership with the Minnesota Community Health Worker Alliance and other key stakeholders to support the enhancement of the community health worker workforce in Minnesota. My previous experience includes working with the Safety Net Healthcare System, where I led the integration and growth of community health worker programs and services within healthcare home certified clinics and hospital systems. I'm happy to be here today to provide background and to serve as a moderator of today's webinar. We have an excellent lineup of experts presenting today. At this time, I'll provide a high-level introduction or overview of the speakers, and then each presenter will introduce themselves during the presentation. And as we get started, I know you're also filling in other information in the chat, but we'd also love to hear from all of you about how many of you and your organizations currently have community health workers integrated as a part of your healthcare home clinic teams, and how many organizations are currently billing for community health worker services through Medicare or Medicaid. So if you can start entering that information throughout the presentation, that'll also help us tailor the presentation as we go along. Next slide, please. Okay, next slide. I'll just briefly introduce our presenters here. We have Anne Nyakundi, the Executive Director of the Minnesota Community Health Worker Alliance. Next slide. Eric Snyder, a partner with Excelsior Bay Group in collaboration with CHW Solutions. Next slide. And we have Megan Nieto, co-founder of CHW Solutions. Next slide. And Megan Ellingson, co-founder of Community Health Worker Solutions. Next slide. Today in the webinar, we will provide information on the role and scope and training of community health workers in Minnesota in the context of healthcare home certification, as well as what you're all here for is guidelines and resources for the new Medicare billing codes for CHW services, as well as opportunities for billing for CHW services through Minnesota healthcare programs. Next slide. So many of you already know the role and scope of community health workers, maybe community health workers yourself, or have community health workers integrated into your healthcare home teams. For those of you that do not, I will review the APHA, American Public Health Association, and Indian Health Services definitions. According to APHA, a community health worker is a frontline public health worker who is a trusted member of or has an unusually close understanding of the community served. And this trusting relationship enables community health workers to serve as a liaison or intermediary between health and social services and the community to facilitate access to services and improve the quality and cultural competence of service delivery. Community health workers also build individual and community capacity by increasing health knowledge and self-sufficiency through a range of activities such as outreach, education, informal counseling, social support, and advocacy. And community health representatives are the frontline health workforce focusing on improving social determinants of health for underserved populations to decrease health inequities across the country using a community-based approach. Next slide, please. There's a large body of evidence that shows that community health workers can impact health disparities, cost, quality, and satisfaction, including the foundations of the triple aim and the quadruple aim. There are numerous studies to support this body of evidence, as well as many healthcare home certified clinics and systems in Minnesota that have been able to demonstrate these outcomes as well. Next slide, please. Today, we hope to make the connection of the community health worker role and scope within healthcare home certification and practice, especially as it relates to the progressing levels of certification that recognize evolving primary care models to reduce disparities, improve value, and address population health. And community health workers integrated within healthcare home clinics and communities play foundational roles that contribute towards these goals and outcomes of progression, particularly as it relates to enhancing whole person care, addressing SDOH, cultural and community-focused care, and focusing on population and community health improvement and reach. So our first speaker, Anne, the Executive Director for the Minnesota Community Health Worker Alliance, will elaborate further on the CHW scope in the context of Minnesota and healthcare home certification. Passing it off to you, Anne.
Thank you so much, Kristen. That is a wonderful introduction, and I am so excited to be here today to speak. Again, I'm Anne Nyakundi, and I'm the Executive Director of the Minnesota Community Health Worker Alliance. You may advance to the next slide. My background is an interesting mix of Spanish, medical anthropology, research. I have quite the global health experience doing research in China and in the Dominican Republic as well. My professional experience in Minnesota starts with working in a public health system, graduating my way up to the role that I have today. I have a background as a community health worker working at Hennepin County Medical Center. And I'm excited to be able to talk with you in depth in this position about the scope and role of practice for a community health worker. Next slide. So the Minnesota Community Health Worker Alliance is a nonprofit statewide partnership that is very much committed to advancing health equity. Our mission at the Alliance is to build community and systems capacity for better health through the integration of effective CHW strategies. We support this mission in a variety of ways, including offering scholarships, apprenticeships, grants, CHW training, CHW supervisor training through employer roundtables, technical assistance, and so much more. Next slide. A couple of things with an audience this big I wanted to make sure I honed in on right away is that we're currently reviewing the CHW certificate curriculum, which I'll talk about shortly. As an alliance, we partner with a Min-State system to review that curriculum periodically, and with all of the additional support going into community health workers these days, it's really critical to make sure that the curriculum is aligned in a way to support billing and reimbursement. And another aspect to the work, as I mentioned before, we're offering scholarships. We have a priority deadline of July 7th. So really, really, really important for you all to know that each scholarship provides up to $3,720 per student. We are offering that. Also in the state of Minnesota, St. Catherine's University is offering that as well. So please connect with us if you want to learn more. And as I also mentioned regarding apprenticeships, we're currently offering a $7,500 stipend per CHW. If you want to learn more about that, money, 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 let us know, get in touch. I've linked our website to the slide. Next slide. And actually you can go on to the next slide after that too. So when you look at the work of CHWs in Minnesota, the current regulation does not really have, there isn't a regulatory entity that enforces compliance or defines professional standards for CHWs. So think in terms of licensures and certifications. However, there are payment regulations in place with Medicare and MHCP, which we'll learn about later on this call. And with the release of some of those newer funding sources through the 2024 physician fee schedule, that'll invite us all to revisit regulation in terms of further defining professional standards. And the Alliance has secured funding in partnership with the health department to specifically bring different stakeholders together to ensure that we can continue to advance the impact of CHWs in Minnesota as a profession. Next slide. So when it comes to the curriculum itself, as I mentioned, the Alliance co-manages a statewide standardized curriculum that includes approximately 14 to 17 credits from post-secondary institutions. The curriculum covers essential areas such as CHW role, advocacy, outreach, cultural health, communications, teaching and capacity building, documentation, legal, ethical responsibilities in community health, health promotion competencies. This core curriculum is also supported in part by an internship, about 80 hours, as well as ongoing now with the Alliance. We have a 12-month apprenticeship program as well, where we're working with the Department of Labor and the Minnesota Department of Health to increase the number of CHWs trained in practice that way as well. Next slide. Delving deeper into the roles themselves, one thing to note is that I've kind of separated into just high buckets, and so I think these buckets are really important as you think about the different ways the CHWs can be involved in a healthcare home setting, in many settings actually. But for the first one, bridge, so bridging the gap between communities and health and social service systems, they enhance care and quality by improving communication between providers and patients. They also educate community members about healthcare utilization and inform the health system itself about community needs. For the second area, navigating health and human service systems, CHWs increase access to primary care. They coordinate services and teach individuals how to obtain appropriate care and enroll in necessary programs needed to improve their health. For the third one, advocating, this is a rather broad one. We were just discussing this recently. In the context of the CHW scope, we're talking about advocating for both individual and community needs. So CHWs are trained to articulate and advocate for community and individual needs. They involve participants in self-advocacy, and they map communities to support needed services. For the fourth one, providing direct services. This is one many of you who already employ CHWs know very well. They promote wellness, they assist in chronic illness management, and they link patients to preventative services and support groups, as well as conducting outreach. And finally, they build individual and community capacity by addressing social determinants of health. They mentor other CHWs and, of course, seek ongoing development. Next slide. So I thought I would break this down just very briefly so you have documented exactly how the scope of a CHW fits into the context of the certification requirements for the medical home model in Minnesota, which of course is the healthcare home. And so for standard one, we have here, it requires continuous patient access and effective communication. So CHWs do this by enhancing that patient-provider connection. They act as a bridge between the patients and the health systems. And you can see there how the curriculum, the specific aspects of the curriculum align with that work. Next slide. For the third standard that we have for healthcare homes as it relates to the CHW role, it involves systematic care coordination. And so CHWs support this by assisting with scheduling appointments, following up on care plans, ensuring patients adhere to treatments. They help identify social determinants of health that may impact care and improve overall care coordination or the effectiveness of care coordination. Next slide. Also, for standard 3, ongoing. So in addition to care coordination, CHWs establish and maintain partnerships with community resources to support that whole person care. They identify and map community resources, provide referrals to social services, and connect patients with community-based support. And again, you see how the curriculum is aligned to support that. Next slide. For this particular standard, we're talking about standards 1 and 4, which emphasize engaging patients in their care plans through shared decision-making and self-management education. So CHWs educate patients about their conditions. They teach self-management skills and empower patients to participate actively in their care. They have training on motivational interviewing, for example, and they provide personalized education based on cultural and linguistic needs. And this is perhaps where they are most powerful as a resource on your care teams. Next slide. For Standard 5 and the CHW role, you'll see here that it focuses on using data to inform quality improvement efforts. So CHWs actually have training on collecting and reporting data, specifically as it relates to their patient interactions, documenting barriers to care and outcomes. And that is all data that is very helpful. An evidence-based way to go about quality improvement, right? Using data. So all that data is helpful for QI initiatives and ensuring continuous improvements to patient care overall. And next slide. And I think that is it. So it was a pleasure speaking with you. If you have any questions, my contact information is there and I will keep it rolling. Thank you. Turn it back to you, Kristen.
Thank you, Anne. Now that you're familiar with how community health workers contribute to the healthcare home model, we will be transitioning to share more information on the billing opportunities for community health worker services through Medicare and Minnesota healthcare programs. As you know, billing and reimbursement is one way that healthcare home clinics can support the integration and expansion of community health workers within care teams. As you may know, since 2009, Minnesota Healthcare Programs, or MHCP, has covered community health worker health education services. And new in 2024, both CMS and MHCP provide coverage for new SDOH-related services performed by community health workers. So now I will hand it off to Eric to discuss the new Medicare guidelines for CHW services. Next slide.
Great. Thank you, Kristen. I appreciate it. Hello to everyone. Just by way of a very quick introduction, as Kristen mentioned, my name is Eric Snyder, and I am part of a firm called the Excelsior Bay Group. We work primarily with 501c3 nonprofits around the state. And prior to joining the firm about 10 years ago, I had a background in healthcare in Minnesota. I had the opportunity to be the original founder of what is now Prime West Health, which is a managed care organization that provides PMAP services in the northern, kind of northwestern part of the state. And I spent about a decade at Optum Health working in product development and innovation before I moved into the nonprofit sector. I'm very happy to be with you here today. The reason that I'm here and my portion of the presentation is focused on some work that I was able to do on behalf of Megan and Megan of CHW Solutions, who you'll meet here in a moment. And as part of that work, I was able to study the recent coverage of community health integration services, or CHI services, by fee-for-service Medicare. And that's important because CHI services are able to be delivered by community health workers and other auxiliary personnel. Just to sort of lead off here, I'm going to go through 3 slides fairly rapidly. And those slides are really intended to sort of talk about the care model that's envisioned as it relates to CHI delivery for this population. I wanted to talk for a moment about the process, how those CHI services are approved and delivered, and then finally how those CHI services are intended to be reimbursed. So if you would go to the next slide, we can talk for a second about the general care model. So one thing that I will point out is that all of this information comes from the final rule that CMS delivered at the end of 2023. And this is all new and has gone into effect as of January. So this is sort of a work in progress, and there may be questions that come up today that there isn't an easy answer for. But what I've tried to do here in the following slides is summarize the information and the model that was called out in the Federal Register. So one of the things that's important to know is that there is no legislative authority for CHW organizations to bill Medicare directly. And so the way that CHI services need to be delivered through fee-for-service Medicare is through through an ordering provider. And that person needs to be the patient's primary care provider. And once and all of the services need to be overseen by that physician in this context. CMS, as I mentioned, refers to the services here as community health integration services, and they can be rendered by CHWs or other personnel who are providing those services incident to that patient's primary care and under the general supervision of their billing practitioner or primary provider. Under the rule, CHWs can provide services that are intended to address specific social determinant of health needs. And as you can see here, those services can include a person-centered assessment, practitioner home or community-based care coordination, health education, building patient self-advocacy skills, healthcare advocacy, healthcare access and system navigation, facilitating and providing social and emotional support, and leveraging lived experience when applicable. Next slide. So before CHI services can be delivered, there needs to be an initiating visit, which is provided by the billing practitioner, usually conducted during an evaluation and management visit or an E&M visit. And during that E&M visit, the billing practitioner or primary care provider needs to perform an SDOH assessment on the patient to identify any SDOH needs that are significantly limiting the practitioner's ability to diagnose and treat that patient. And you'll see a footnote that Medicare does not call out any specific SDOH assessments, but does say that they should be tested and validated through research and include domains for food insecurity, housing insecurity, and transportation needs. So there's some discretion about which assessment is used, but they need to at least follow those domains. Once though the assessment is done, the auxiliary personnel delivering the CHI services must be certified or trained to perform all service elements and authorized under applicable state law and regulations. So again, CMS doesn't call out what that is, but defers to the states in terms of what the requirements would be. And billing practitioners can either provide these services through their own in-house staff, or they can partner with community-based organizations to provide CHI services on behalf of their patients. Next slide, and this is the last slide and probably the most of interest to the folks on the call. The way that these services are coded and reimbursed for is when the social determinant of health needs are identified, they can be captured using ICD-10 Z codes. In terms of units of service, CHI services are billed monthly through the billing practitioner's office. There is a code for an initial visit, which is a 60-minute visit per month that's billed using a HCPCS G code, G19. And any subsequent time spent with that patient for that calendar month can be billed in 30-minute increments under the add-on G code of G22. And as of the rule today, there is no frequency limit on G code G22 as long as time spent is reasonable and necessary. And CMS, one of the things that's different from Minnesota Medicaid is CMS does not provide billing codes or reimburse for CHI services provided in a group setting, which is something that's maybe of note. In terms of claim submission and reimbursement, services must be provided incident to and under incident to professional service of a physician or statutorily qualified practitioner who must bill for those services. The auxiliary personnel who provide these services must be under their general supervision. And currently reimbursement rates for the two G codes I mentioned is $79 per hour for the initial visit, the G19 code, and the add-on code of G22 is anticipated to pay $49 per 30-minute increment. Also calling out that CHI services are currently available to individuals enrolled in Minnesota healthcare plans. And at the bottom, the model and the reimbursement description I just gave is for garden variety provider offices. there's a special call out that also allows FQHCs and rural health clinics to take advantage of this new coverage. In the case of FQHCs and rural health clinics, CMS decided to allow those kinds of institutions to use an existing G code, G511, can now be used to cover the delivery of CHI services as well as some other services. And there are some references with more detail at the bottom of this slide if you have further questions. So that's a quick and dirty overview of how fee-for-service Medicare is planning is now beginning to cover community health integration services. With that, I will turn the floor over to my colleagues, Megan and Megan of CHW Solutions.
Hi, thanks, Eric. And hello, everyone. I'm Megan Ellingson. I'm happy to be here today to talk about Minnesota Healthcare Program billing. And I am one of the two co-founders of CHW Solutions, as you've heard already. Next slide, please. So here is our contact information. Megan Nieto is going to be joining in just a few slides. But here's our contact information, our website, if you'd like that. Next slide, please. And so our learning objectives for our part of this webinar today is that participants will be familiar with billing requirements outlined in the DHS Minnesota Healthcare Program CHW Provider Manual, that you will understand how to bill CHW services for MHCP recipients, and you will know where to go for further technical assistance and claims troubleshooting support after hearing from us today. Next slide, please. And so a little bit of background on CHW Solutions. We launched back in 2016, so we've been around for about 8 years. When we launched in 2016, Minnesota Healthcare Program reimbursement for CHW services had been available for 7 years, but in Minnesota, only one organization in Minnesota was actually accessing it. And so Megan and I realized that we had a lot of background both in our professional lives, actually delivering CHW services ourselves, as well as experience working at community-based organizations and public health, billing health plans for community-based services delivered to Minnesota Healthcare Program recipients. And so we wanted to bring those backgrounds to the table and show how we can further expand MHCP reimbursement for CHWs in Minnesota. We're based in St. Paul, but we do have a statewide service area. And we are dedicated to developing sustainable models for CHW services. So like I mentioned, when we began CHW Solutions, we really designed our model around the requirements of Minnesota healthcare programs to assure that our services would be billable. We always talk about how we deliver services in 3 different service buckets. We have our direct CHW services. We have about 10 or 12 CHWs on board at our organization right now. Our largest team works with the Department of Human Services Resettlement Program Office, and we serve Minnesota newcomer residents who are here under humanitarian protection. So that's our largest direct service team, but we also serve other populations like kids with asthma, seniors, people with chronic conditions, other focus areas. The second bucket is that we provide clinical oversight and claims submission for CHW teams at other organizations that don't have those functions in-house. So we have a medical director, Dr. Ron Jankowski, and he provides general supervision of our own CHW team as well as the CHW teams at other organizations. And the last bucket is that we provide technical assistance and consulting to help other organizations either move into providing CHWs, move into billing for CHWs, or developing their best practices and their service models. Next slide, please. And so a quick agenda of our section of the webinar. We're going to give an overview of CHW services, some provider manual basics of the CHW provider manual for CHWs, how to enroll CHWs with DHS, how to deliver billable services, documenting those services and which billing data points need to be provided, how to comply with all of DHS's rules, submitting a CHW claim, and then troubleshooting claims, and then also how to communicate with DHS and the health plans that you're working with to serve MHCP recipients. And the graphic here is from Healthcare Home's Learning Days in 2018, where we presented along with Otter Tail County on some pilot work that we did, where we implemented steps helping them in Otter Tail County begin CHW services. They did not have CHWs before, developing their service model, and then also billing Minnesota healthcare programs for the services that they provide. And this model is something we have followed many times with many other organizations, sort of this incubating of an idea and developing policies and practices for the CHWs that both meet the values and the service model of each individual organization, as well as meet the DHS requirements, and to train various organizations who are close to the communities that are being served in how to access Minnesota Healthcare Program billing. Next slide, please. And so a quick overview of CHW services. Some of this you've received earlier today. I just want to highlight a few things in the second bullet, that CHWs really extend the reach of providers into underserved communities. And Megan Nieto is going to discuss how with Minnesota healthcare programs, standing orders can be used to engage populations and bring them into healthcare. So it can be used a little bit differently than the Medicare service model and codes that Eric went through. And that when the CHWs help people engage in primary care initially, and then also work directly with primary care providers and others on the healthcare team to serve the patient as a whole person and work on health coaching, motivational interviewing, accessing resources that people need in order to manage their conditions. CHW services are a diagnosis-related medical intervention. They're not a social service. But it is important to remember that preventive services can be included in CHW services. And for instance, at CHW Solutions, we always use the diagnosis code Z71.89, which is for other counseling. And so that can be used for both people who have a diagnosed condition already, but also for preventive and health promotion visits that we do. Services that are delivered to recipients of PMAP who are being served by managed care organizations. It's important for the organization providing the CHW services to connect with each of those MCOs and learn about their enrollment requirements and if they have policies that are specific to those members. And then the last bullet provides a list of the types of clinicians who can provide general supervision to CHWs under Minnesota healthcare programs. And then before I turn it over to Megan, I just want to reiterate one of the last things that Eric said, which was that once the Medicare codes and service model was approved nationally at the federal level, Minnesota DHS decided to also make those same codes and services available to people on Minnesota healthcare programs. And so those Medicare rules that Eric covered are now also inserted into the Minnesota Healthcare Program Provider Manual so that those services are available to MHCP recipients. So kind of keep that in mind, that both the Medicare approach and the approach that Megan Nieto is going to be talking about are available to MHCP enrollees. And with that, I'll turn it to Megan and we can go to the next slide.
Thank you, Megan. Hi, everybody. Nice to see you all today. So I'm going to dive into a little bit about CHW billing from the perspective of the DHS Provider Manual. And as we all know, the provider manual has lots of rules, and those rules are there to keep us in our lane, keep us in compliance, and to help us understand what are the expectations and things that we need to be doing to make sure that everyone is delivering billable services and that our agencies are confident that we are billing and submitting claims for billable services. Next slide, please. All right, so the provider manual basics. So my slides have a lot of information. I wanted to make sure that there's enough information in there where you can go back and look at the slides and pick out information that you wanted to get it have more learning on, or dive into the provider manual and figure out what's there. But if you're unfamiliar with the CHW provider manual, it is on the main DHS website. Community health worker has its own portion of the provider manual that has all of the rules, all of the eligibility, who the clinical professionals that can be supervisors, who can actually deliver CHW services, and it has sections for billing that'll give you all of the information that you need. It's your primary source of information to make sure that you're billing billable services and that everyone is staying in their lane. Now, this does change periodically and sometimes frequently. DHS may make minor changes. They'll change words, which can have a big impact on services, on supervision. So our recommendation is to just always go out to Google and Google it fresh, because you never know when they're going to actually make small changes. So no need to print it out because it might be outdated fairly quickly. And as providers, it is our responsibility to check frequently and make sure that things that we are doing are still in the provider manual and we're still in our lanes. Another thing to be familiar with is that they have a fantastic call center. This is the number. The first layer of humans can answer a lot of questions. And if they can't answer questions, then it gets, they create a case and it goes to a trainer, and a trainer, depending on the specific area of DHS that you need. There's specific trainers that are assigned to community health worker, and they will call you back so you can explore more information. All right, next slide, please. So one of the first steps that we have to do once your CHWs get their certificates in their hands is they're going to apply for that NPI number. And then they are going to complete the enrollment with DHS. And that enrolls them as a provider so that they can appear on the claims. If you're billing through minutes for straight MA, they will be the rendering provider. And then depending on your contracts, the payers may or may not have the CHW as the rendering provider. They may have your agency, depending on what your provider type is, or they may have the supervising provider, the ordering provider. It just depends. But the biggest thing to start out with is all community health workers must be enrolled with DHS. And you can use the portal, the new portal, have the community health workers fill out the information, the forms, and then you can upload the information onto the portal. DHS will always confirm provider enrollment with a welcome letter that comes in the mail. They'll be watching for that. And always remember that if the application goes incomplete or it gets submitted without a copy of the community health worker certificate, that could present significant delays. Every time there's something that has to be fixed or redone or added, it potentially adds at least 30 business days onto that provider enrollment and getting all of that moving with DHS. Next slide, please. All right, so delivering billable services. So keep in mind that our entire model is based on billable services. So some agencies may have community health workers doing activities like going to health fairs or going to employment fairs, those types of things where they're out in the community. Those are not billable services. So CHWs do a wide variety of activities. Our focus is on delivering billable services. So when community health workers start with us, even if they are trainees, and they don't necessarily have their certificate yet, or they're going to CHW school, we are getting them started with health education, patient self-management skill building, and connection to health-related for community resources for health-related social needs. This gets them started in a lane that's going to be billable once they get the certificate in their hands. Once they are comfortable with those activities, then introducing a health fair or having them do other outreach activities or establishing referral streams, those types of activities are fine, but we really want them to understand the 3 buckets and that is their main job to keep everybody in compliance with DHS. Next slide, please. Documenting services and billing data points. Again, a DHS compliance piece. This is the required documentation, which is also in the provider manual. So you must have an order for services signed by an MHCP enrolled physician, APRN, dentist, mental health professional, or a non-enrolled registered nurse or public health nurse working for an enrolled organization. So the public health nurses must be working for the county, and the county must be enrolled with DHS. Okay, the documentation of the patient education plan or the training program that's used by the community health worker. So those curriculums that you're using within your organizations to deliver the patient education, those are things that must be in the documentation. The periodic assessment of the member's progress and need for ongoing community health worker services. So this is a touch-in with either, in our case, it would be the ordering provider, the supervising provider, it's the same person. It may not be the same person in your organizations, but the person that is giving the clinical supervision to the community health workers. We run our patient panels, and Dr. Jankowski will say things like, stay the course with the patient, include nutrition education, include increasing physical activity, or he'll say things like that patient needs to get back in touch with their primary care provider. Please help the patient make an appointment. There's lots of different ways that this can shake out, but he must say that yes, this person needs ongoing CHW services. Documentation of the following, so the date of service and the exact start and end time for the service. This is very important. They're not just rounding up or rounding down to the nearest hour or the nearest 15-minute increment. So it may not match the way that they record their time for HR purposes and paycheck purposes, but their documentation, if they start the visit and they arrive at 9:58, the start time should be 9:58, not 10 o'clock. Or yeah, not 10 o'clock. And then whether the service was a group, an individual, and if it was a group, how many total patients were present? We're not just talking about the patients that have MA, but we're talking about the total group number. And a summary of the session's content, figuring out how to summarize the content of the group and putting that as in a smart phrase or something similar in your EHR so it can be quickly documented. It doesn't need to have every single data point of all of the entire curriculum or all the information, but something brief. But that is a summary of what was taught at that, taught or discussed, or what activities were done during that session. And then there's CHW's signature or their print and or their printed name. If they're documenting in an EHR, chances are they're going to be logged in under their own account. If they're documenting on paper, they could simply sign at the bottom. Next slide, please. So for submitting CHW claims, they are submitted electronically using the CMS 1500. They're going to be using the NPI of the organization or the NPI of the pay-to provider, which would be the physician. So either way, in our case, we use the NPI number of CHW Solutions and the NPI number of our medical director, Dr. Ron. Some organizations might be different, so it's important to talk to the payers about how exactly they want everybody on the form. This is a list of the codes so that you can see something that was recently few years ago now added was letter D for groups of more than 8 patients. They added a U9 modifier, so it's the same 98962. And then in the first modifier box goes a U9. You're always billing in 30-minute units. Here's the limits. There are limits. Although 24 units or 12 hours, if you're kind of doing that in hours, a month is quite a bit of face-to-face time with patients. You're billing in separate lines, so each day of service has its own line on the CMS 1500 form, and you can only bill 1 month at a time. So you can bill all of your claims or service dates for April, but you can't add any for May. May needs to be on its own form. Again, Megan talked about this diagnosis code Z71.89. Before we started billing CHW Solutions, we did a bunch of crosswalking with the CPT codes and this diagnosis code on the online platforms. And we confirmed with the payers and DHS that yes, this will all mesh up together. And we've been using this diagnosis code ever since without problems. Again, CHWs are non-pay to providers, so we do have an MPI number. But if you're billing on minutes, this is more important if you're billing on minutes because you will need to know the NPIs of all of your community health workers so that you can pull them up as the rendering provider. All right, next slide, please. So this snapshot is what the CMS 1500 form looks like, kind of that classic red. Depending on the billing platform that you use, it might be the actual claim form that's red with boxes or fields, or it might the platform might be capturing the information in just straight fields and then they're submitting it electronically. So you're billing a payer or a health plan for a patient that has MA or Minnesota Care, SMBC, MSHO, MSC Plus, those Medicaid products. And then you're also billing for a dual eligible. So if their Medicare is primary, you can bill as a dual eligible for the community health worker services. You'll be billing on that CMS 1500. There's every clearinghouse that can submit claims can also submit CHW claims. We at CHW Solutions use Minnesota eConnect. It's a freestanding clearinghouse. It's not connected to any of the EHRs, but it does connect to thousands of payers across the country. And then you're going to use minutes if you're billing straight to DHS for fee-for-service patients that have MA as primary. You're also going to do that if you have dual eligible patients where their Medicare is primary, but then their medical assistance is straight through the state. Next slide, please. So there has been a list of billable activities that was developed a few years ago by the Healthy Communities Task Force. And if you don't have a copy of this list and you're interested in it, it's a fantastic guide. Page 2 has a laundry list of billable activities. You can pretty much take any chronic condition that you are educating for and put it in there and figure out if the activities that your CHWs are currently doing are billable activities. If your goal is to increase your reimbursement, keep in mind that 60 to 70% on average of your community health worker time needs to be face-to-face with patients in order to be sustainable or to increase or reach your sustainability goal. Scripting can help community health workers become comfortable while using a tablet or a laptop in a home. So if they're trying to do their documentation at the very end of their patient visit, helping them with scripting can be a game changer. And then additional IT or HIPAA considerations when they're documenting outside the office, especially if people are working in the community and they're working at home, making sure that they have enough technology or the appropriate technology where it's going to keep patient information safe. And always remembering that MHCP does not cover social services. So MNsure navigation, they don't cover MNsure navigation for community as the community health workers. Can CHWs be MNsure navigators? Sure can. But the CHW reimbursement will not pay for the enrollment assistance. And then case management or advocacy delivered by a CHW. The other thing to remember is that when you're billing these CHW codes, we can't just only work on housing. We can't just only help people get orthotic shoes. We have to integrate or braid in the health education and patient self-management skill building pieces in with the community connections. Next slide, please. All right, so meeting the requirements, there's quite a few requirements that are included in the provider manual. Some of the trickier ones are identifying a supervising provider, somebody that really understands the CHW component and is going to be an internal champion for referrals, managing referral streams, keeping referrals going, helping talk with their colleagues. A lot of those things can really, really help increase referrals and keeping the community health workers busy. So this is all in the requirement, and we've also talked a little bit about it. So I'm going to go ahead and go to the next slide. All right, so quickly for standing orders. So CHW Solutions, we pioneered standing orders as a way to have an order that is used to delivering services for an identified population. So whatever the population of individuals that you're serving and the criteria that qualifies them for community health worker services, we are able to put that into a standing order, and then they don't need to be seen by a clinical provider first. So for example, you might have a population of individuals with diabetes. So you would set parameters, you would set curriculum for who they are, maybe where they live, maybe what their A1C is, and then you would go from there and figure out what is the denominator in that population. Is it enough people within your clinic or within your system to be able to have your community health workers delivering services without that patient having to go to their primary care provider every time? In our case, because we deliver services from the community, meeting people in the community and then having them go to their PCP first to get an order, that it would be a real tough battle to be able to get that information back and be able to deliver services. So we create a suite of standing orders depending on the condition and the population that's served. We create them with our medical director. He signs off on them, and then connected to that is a best practice. So we are using credible sources to develop documents that keep our community health workers in the right lane, and then it matches together the standing order and the best practice. So you're going to be talking about how at-risk clients are identified and the criteria for the clients to be served. You're defining the population, and then how will the best practices be delivered to at-risk clients? So what information is in there? Where do you want your community health workers getting their health education information from? What are some talking points, some scripting, some opening questions using motivational interviewing, kind of these classic community health worker pieces? You're going to want all of that in there so that the community health workers can take the document, and then it keeps them away from rabbit holes on Google and potentially stumbling across information that may or may not be credible. Also, the ordering provider signature must be on there. What standing orders are not? So it is not a way to deliver general education services to everyone. We cannot stand at bus stops and say, hey, everyone, we're community health workers and we want to help you, and then just randomly start helping people delivering services and billing MHCP. That's not how it works. What we can do is we can have a standing order for patients with, let's say, prediabetes, and we can go and we can use the American Diabetes Association risk screening tool to go to places such as maybe the Salvation Army for lunch, briefly chat with people, have the risk assessor or the risk tool there. If they score at 5 and above, they may potentially be good individuals that we would be able to serve. Hi, Kristen.
We have about a few more minutes before we need to transition to the Q&A. Thank you.
Yeah, perfect. So let's see what the next slide is. Troubleshooting rejected and denied claims. There's some classic things to do here. I'm going to skip over this one. Oh, and there we are. Um, so Megan and Megan, so we're the two co-founders. Here's our information. Please feel free to reach out to us if you have questions, if you've been stuck places, trying to get claims to go. We can help you.
All right. Thank you so much, Megan and Eric, for the detailed information that you provided related to both the CMS billing guidelines for CHW services, as well as the MHCP guidelines for CHW services. And there are a number of questions in the chat specifically related to that. I think somewhat about the distinction between those two guidelines. But there's some questions about who can be the provider for an initiating visit for Medicare, essentially who can be the billing supervisor. And I think the answer to that might be different that for CMS versus MHCP. But I'm wondering if Eric, if you want to answer that. There's some questions about if a dental visit counts, a PHN or RN, and who can be the billing supervisor.
Perfect. So while we were talking here, I did find an FAQ that CMS published that gets to the question of who can be a billing practitioner. And I'll send this document to you, Kristen, so you can add it to the website. But the FAQ says, CHI services can be furnished and billed by physicians, nurse practitioners, certified nurse specialists, certified nurse midwives, and PAs, and must be billed by the same physician or practitioner who performs the initiating visit. So those are the provider types that are, I think, legislatively allowed to bill the physician fee schedule. So that's the answer that I have for today, at least as it relates to fee-for-service Medicare.
Great. Thank you, Eric. And then if you're looking for I don't know if one of the Megans wants to jump on, that is different than for the CHW education services, those codes that are in the MHCP manual. I think those were outlined in CHW solutions slides. Is there anything you wanted to add, either Megan or Madigan, to the supervising, general supervision and billing provider for Minnesota CHW education services?
Nope, I don't think there's anything to add. Just look at that bullet in the slide or in the provider manual.
Okay. There was also a question, I think this was related to the CMS rates that you provided, Eric. Are the rates listed the billed amount or the reimbursed amount?
Yeah, another good question. I see them referenced as the national payment amount, which indicates to me that's the amount that the provider will be paid by CMS. Not, I think the questioner is asking, is there a discount? You bill a certain amount and get reimbursed less than that billed amount. My read is that these are the amounts that CMS has said they will reimburse for these services at. So I don't think there's a discount that needs to be factored in. But I will ask Megan and Megan if that's their understanding as well.
Yeah, that is my understanding.
Okay.
And
Thank you.
yeah, there's also an example of a clinic in South Dakota that has successfully billed for using these codes. And I think we would have heard if it paid less than what the rates are that Eric shared.
Great. I know we only have a few minutes left and there's a number of other questions left in the chat. I'm wondering if maybe we might be able to save some of those questions in the chat and be able to follow up with them past the webinar. But I'm wondering, Eric, can you speak to the implications of the new federal guidelines related to FQHCs?
Yes, just very, very generally. And we have a couple of documents that we can send you, Kristen, that we've just discovered in the last few days. But I think the implications are that at a high level, CHI services are eligible for reimbursement if you're an FQHC or a rural health clinic. CMS, rather than having you use G code 19 and 22 for those services, stipulates that those services, when billed by an FQHC or a rural health clinic, need to use the G code G11, which is already in use for some other services. And I think because it's already in use, and I don't think any modifiers were stipulated by CMS, there's kind of a gray area in terms of how those clinics are supposed to use the 511 G code. But they are eligible to bill for CHI services, and we can send along the information we have, I guess, with the caveat that there may be some gray areas still to be fleshed out.
You know, and Eric, what I would just add to that then is that in Minnesota, FQHCs, you know, because DHS has added those Medicare codes and rules to the MHCP provider manual, that you know, FQHCs could also bill their patients who are on Minnesota healthcare programs using the codes, the G codes that were developed for Medicare.
Hello, everybody. Carol Bauer here again. I'm going to have to break in and end this wonderful webinar. My goodness, I mean, our stakeholders always just tell us how to do things. And in this webinar, we've gotten so much practical information and obviously information that people want. So we will, for those of you who asked, this webinar is being recorded. And yes, we can follow up with some of these questions. We'll work with Kristen and her team to get answers out and get them out to everybody who attended. I think we can do that, right, Sadie?
Yes, I believe so. I believe we can download the chat.
Okay, fantastic. Well, I'd like to thank you, first of all, to all of our presenters. This is fabulous information. And so thank you for doing all that. Here's the references. The slides will be uploaded to our website, so you can grab them there. Thank you to everybody who participated today. Thank you, Sadie, for running the controls for us. And just to let you know, the evaluation and certificate of completion will follow. And to let you know that we have some upcoming webinars, one on July 16th. That'll be a repeat of one of our Learning Days presentations that was very popular and very well received, and another on August 13th on oral health. So with that, I'm going to have to let you go. It's after 2. Sorry to keep you a couple minutes late, and thanks again for coming.